So it looks like today we'll finally be looking at some fetal heart rate and fetal tone related topics as we approach the normal labor and delivery concept. So right here we have something relevant to what we finished off at last time, elective termination of pregnancy. Last time we looked at spontaneous abortion and the various types of abortions that you could have and how they were all different from each other, whether the cervix was open or not, whether the components of the pregnancy came out partially or completely, stuff like that. So now we're looking at elective termination of pregnancy, where it wouldn't be a spontaneous abortion, but rather an abortion that a person is getting because they need it. It has been estimated that 50% of all pregnancies in the United States are unintended. Some 25% of all pregnancies end in elective abortion. Options for elective abortion depend on gestational age and patient preference. If fever, vomiting, purulent discharge, and/or hemodynamic instability are seen after an elective abortion, septic abortion should be suspected, which is definitely a high yield question. You would often get some kind of patient who maybe had on step. It's rarely ever a legitimate abortion. So a legitimate abortion is someone who definitely needs the abortion for medical purposes. Like maybe it's a molar pregnancy, maybe it's an ectopic pregnancy, maybe it's a pregnancy where if the woman carries the pregnancy out, then delivering the baby may actually kill the mom. Right? That's another case scenario. That's obviously a very legitimate pregnancy. An illegitimate abortion is where a woman is getting an abortion simply because she wants to. Right? That's never the case in a step question. I've never seen that because that's just it is what it is. So usually you'll have questions where someone has some kind of a problem with the fetus, right? So something is wrong. And then the abortion is going to take place, and they'll tell you they did the abortion. They'll tell you whatever procedure they used for the abortion. They might even mention they did a DNC, but rarely do they actually say they did a DNC. Because if they did the dilation and curettage, they would have cleaned everything out very well. So when they say that an abortion occurred, but they don't say that a DNC occurred, that's something for you to think of, like, oh wow, you took, you did the abortion, but you didn't clean up. So then at that point, there's a chance for septic abortions, and then there's also a chance for DIC, both of which are extremely high topics. So the septic abortion concept is another legitimate abortion where the mother is really sick, hence the fever and vomiting, and then the hemodynamic instability leads, occurs after the elective abortion. Right? So something weird has happened, and we'll see that in those practice questions when we get there. This is a medical emergency that requires broad spectrum antibiotics and immediate surgery to remove any infected tissue that's there, right? And that's always going to be the answer choice you're going to pick. Elective termination of pregnancy. So here they have the first and second trimester. Um, the abortion-related laws vary by state for the most part because this is America, but we don't need to know the state by state differences. All we really need to understand is that generally speaking, nowhere can you actually get an abortion in the third trimester. There are states you can, but generally speaking, you can't, right? So that's kind of what we go with. And if a patient is in their third trimester and they're asking for an abortion, then again, I've never seen that in a question, but if it does occur, it has to, the only way you would actually let it happen is if it falls in that legitimate category where the delivery of such a baby would actually cause the mom to die. Then you have to do that third trimester abortion. But I've never seen that in a question. So that's something that doesn't really occur. Right, so you can see here in the first trimester, that's 90% of abortions. Medical management with mifepristone or vaginal misoprostol, right? That can be done up to 49 days gestational age. Um, Intramuscular or oral methotrexate, which of course is going to mess up DNA replication, and oral or vaginal misoprostol. That's another method you could use. The first two methods are very similar. The third one is vaginal or sublingual or buccal misoprostol, very high dose, repeated up to 3 times. Right? You keep taking misoprostol 3 times in a row, and that will just lead to abortion. And that can be done up to 59 days, very quickly approaching basically the second trimester. Surgical management is what you would have to use if you're basically about to approach the second trimester, right? So in the second trimester, you can see that the surgical management is basically the way to do it. Manual uterine aspiration and then a DNC with vacuum aspiration. When the DNC, as I said, is not done, then they didn't do the cleanup, which is a chance for DIC to occur. So very, very key thing to keep in mind. So DNC and DIC. You're going to get one or the other. So if you don't do the DNC, there's a high chance of DIC in that patient. On the left, we could see there's this question about uh, the fetal head and dilation of the cervix graph that's given on the bottom. So now we're going to have to, today, right now, we're going to spend a little bit of time really understanding how this graph is read, what it indicates, and what the different parts of it mean. You can see it has a pink part and a blue part to it. So the question reads, my pencil. So it's a young woman, 23-year-old woman, G1P0, so this is her first pregnancy, at 41 weeks gestation, so that means that she's pretty much about to deliver any second, is admitted to labor and delivery for contractions over the past 3 hours. So she is having contractions, which is only okay if it's time to deliver. If you're having contractions any other time, that's a huge issue. She had an elevated 1-hour glucose challenge test, but normal 3-hour glucose tolerance test at 28 weeks gestation. That basically means she doesn't really have gestational diabetes. She receives epidural analgesia, so we want to highlight anything that we're doing to the mother. Immediately upon admission and has spontaneous rupture of membranes 2 hours after admission. All right, perfect. An intrauterine pressure catheter is placed for variable deceleration. So here comes a term that you may not be familiar with. We're going to learn about variable decelerations as we go on, which resolve with an amnio infusion. So they did an amnio infusion as well. Her cervical exam was shown below without labels, right? So they gave basically this graph, but it wasn't labeled active phase arrest, right? So you don't know it's an active phase arrest. It's just the graph, nothing else. So no, this isn't there and this isn't there in the actual question. And then current temperature is fine. Fetal heart rate is also okay, 140, with moderate variability in multiple accelerations because it's time to deliver. Intrauterine pressure catheter shows an average of 200 Montevideo units every 10 minutes for the last 4 hours. Now, this intrauterine pressure catheter concept is another bit of information that you may not know how to evaluate. Like, what does it mean that she has 200 Montevideo units every 10 minutes? Is that good? Is that bad? So we're going to have to understand that as well as we go. What is the best next step in her management? So given this, right, you can see as soon as you look at it, there's only 2 lines to follow, and you want to make sure you understand all your axes, right? That's something you always want to do. This is going to be true for any graph you ever get. So you can see right here on this side you have the dilation of the cervix in centimeters. On the other side you have the station of the fetal head. They're both on the x-axis because they kind of go together, right? As the fetal head is approaching exit, dilation of the cervix occurs, right? So that makes sense. On the y-axis, you have time, which is an independent factor. So it always goes on the y-axis. You can't control time. It's going to keep moving. So what's happening? Well, they gave you the station and the centimeters, right? So 2 different lines. The black line is showing that the cervix is dilating, right? It went from, looks like 5 over here to 7, and then it's at 8. And it's staying at 8. Right, so it stopped dilating more. It's staying at 8 now. That part is very easy, right? That's something you can clearly read from the graph. Forget anything else. If we're just focusing on the fact that this dark line is the dilation of the cervix in centimeters, we could see it went from 5 to 7 to 8, and then for the next 1, 2, 3, 4 hours, it stayed at 8. You're going to need to dilate the cervix more than 8 centimeters to get a baby out. Right, so that's something that you just have to know. Either way, it should keep dilating more, and you need to get the baby out. So it didn't dilate. That is all you need to do. You could stop there, and now you should understand, obviously, that if the baby's not going to come out of the cervix, you're going to have to do cesarean delivery. That's all the answer was. Right, so the goal of these questions is always going to be to understand how to simplify finding the answer. The more complicated you make finding the answer, the more chances you have of mistake, right? Because there's obviously always going to be a lot of extra information in the question stem that is going to be there to point you in different directions, right? Every sentence is like you're going down a road, you're trying to find directions to which way is home, and you keep asking people. Each person is another sentence here, and each person is pointing in a different direction. So now you don't know who to listen to. So you just want to ask one person, just one person. Hopefully it's the right person. You want to figure out who looks like the least likely person to be a liar, and just work off of that. And to find who's least likely to be a liar, you work with facts, and this graph is a fact, right? No matter what else they might have told you in the question stem, whether she has diabetes, has any other issue, they did the the epidural analgesia. They can try to confuse you with that as well by saying, oh, is it the epidural analgesia that's causing her to be like this? Maybe, who knows? Either way, if it is the analgesic that's causing her cervix to not dilate anymore, you still need to do cesarean delivery, right? If the exit door is not going to open, then you got to get the baby out. 30% of people also chose start oxytocin infusion. Now, oxytocin is used when labor is getting very protracted, not when labor is stopping. Here, this means labor has stopped. And this is really bad because now if we also look at the gray line, the station of the fetal head, the station of the fetal head was at 0, right? Which is supposed to become better. Instead, it's going downwards. It's becoming down to the station of 2, which is latent. Right? This is in latent. So it's an active phase arrest. Right? This is what this graph will always mean. Now, it doesn't have to look exactly like this always. It can look different. For example, your solid line could go something like this and then stop. I can't draw perfectly with the pencil because it's very shaky. But it doesn't have to follow this exact trajectory is what I mean. It could have, for example, just gone like this. Maybe go here and then stay straight. Not falling down, but straight. And anywhere else. It could have come here and go straight. Anything like that. As long as it's basically showing you that there's a straight period where the dilation of the cervix is no longer occurring for multiple hours, that's an active phase arrest, right? So now the door isn't opening, the baby can't come out. As you can see here, normal progression looks significantly more different. Normal progression shows you that this line is never flat, right? The dilation of the cervix has to keep increasing. It should keep increasing by more than 1 centimeter every 2 hours. Right, so this can look different in many ways, but the point is it should never be flat like that. Never should the dilation of the cervix be a horizontal line for more than 1 hour. Right? If it's flat for more than 1 hour, that means it was flat for 2 hours, and if it's flat for 2 hours, that means it didn't increase by more than 1 centimeter in those 2 hours. Right? So it should never be flat for too long. If it's flat for just 1 hour, and then it does that, that's okay. Right, because that means that in the 2-hour period, it went up by 1 centimeter, right? And that's okay. That can be something that if they're really trying to make a question difficult for you, they can do that in a question and try to really make you get confused. But in all reality, you can see this is very long period. That's 4 hours of it being flat. So that's a very obvious active phase arrest. Similarly, when things are going very well, you can see that the station of the head is at -2. That's normal labor progression, -2. And then as labor is actively progressing, it keeps going down, and then you see the baby is going to be coming out. Right, so this line can stay flat. That's okay because it's still waiting. As you can see, this portion correlates with this portion. So the flat part up here for the baby's head is flat because it's waiting for the door to open up more. Once the door opened up more, you can see the head started to come out. And the 2 lines need to cross near where basically the exit is happening and the baby's going to come out. You can see here that the crossing occurred way too early because the numbers are not matching correctly. The station of the fetal head is not at a good spot and the mother's cervix is not expanding. All right, so that's kind of what you're going to be looking at for graphs like this. You're going to see this in more practice questions and you're going to feel a lot more confident as you keep going. They explain that the active phase labor, which is 6 to 10 centimeters, right, from here to here, the pink area, has an expected predictable rate of cervical dilation of more than 1 centimeter every 2 hours. I just call it 1 centimeter every 2 hours. That's good enough. Her labor curve shows that she dilated from 5 to 7 centimeters in the first 2 hours, right, from 5 to 7, crossing into the active phase. Once there, she dilated from 7 to 8 in 2 hours, which is okay because that's the 1 centimeter in 2 hours. However, for the past 4 hours or the last 4 hours, Her cervix has been unchanged despite adequate contractions. So this 200 Montevideo units every 10 minutes was showing you that she has adequate contractions. So that was good. Okay, so now you're learning that, right? Montevideo of more than 200 over 10 minutes. This is telling you that the number of contractions that are occurring in this woman who should be delivering very soon because she's 41 weeks pregnant is perfect. That's exactly how it should be. So there's no problem with contractile issues. You don't need to give oxytocin. Her active phase arrest is likely due to her late term gestation and possible fetal macrosomia because of her potential diabetic status, right? Gestational diabetes, which contribute to cephalopelvic disproportion, a common cause of labor arrest. Oxytocin is used in protracted labor, not labor arrest. Right? So that's the big lesson here for this topic. Let me just check something real quick. Right, so that's it for that. Now they had more explanations, so let's take a look at what they're explaining here. The first stage of labor begins with the onset of regular contractions and lasts until complete cervical dilation, which is 10 centimeters. That's the top of the graph. The first stage is divided into phases. The latent phase, which is 0 to 6 centimeters, the blue area, is the latent phase is when the cervix dilates slowly and has no defined expected rate of cervical change. So you can see how it's dilating very slowly. It took 4 hours to just dilate half a centimeter. That's okay though, right? Because that's not the active phase yet. We're still in the blue area. On your test, it may not be coded pink and blue. Right? They don't need to label it active and latent. This is just the explanation that's doing it. Your question won't have the active and latent part written in it. You have to understand that 6 is the cutoff point. Past 6 is active labor. Right? When evaluating a labor like the one above, you can see the latent phase had a rate of 3 centimeters in 6 hours. So it took 6 hours to dilate from 3 to 6 centimeters. After entering the active phase, the cervix has dilated 1 centimeter per hour. Right? It took 2 hours to go from 6 to 8 centimeters. Right? And they're doing that. They're changing everything from 6 to 8. That's the 2 hours, and it went up 2 centimeters. The associated fetal station, which is the right side y-axis, this one, where am I? Went from -2 to +1, which is consistent with normal progression. Right? You want to be in. If you're inside the mom, that's a negative, and then if you're coming out of the mom, that's when the number is kind of becoming a positive level. Right? So you can see that you're coming out of the mom when this intersection occurs, which this intersection should occur in the upper half of the graph, not the lower half of the graph. This is reassuring status and can continue expectant management, where you don't need to do cesarean delivery or take any medication or anything like that. Right? So that's what this is showing you. This is a great question, very nice graph, both the active phase arrest versus normal labor progression. I haven't seen any other graphs. I'm not sure if there are other things that can occur, but if like now we'll be looking at fetal heart rate monitoring. So if there is anything else, if I find more questions, I'll definitely make sure I put it in the book. But this is the only question I found where they had this graph in it. That's active phase arrest. Otherwise, everything else is fine. The book itself has a little question right here. It says a 23-year-old G1P0 woman at 15 weeks gestational age presents with abdominal pain and mild bleeding from the cervix. So these are red flag symptoms, right? She's young. It's her first pregnancy. She's 15 weeks pregnant, and now she has abdominal pain and bleeding. Bleeding from the cervix is never a good thing at this point in pregnancy. On pelvic exam, some POC are found to be present in the vaginal vault. What test is necessary to determine the next step in management? So clearly this is a type of abortion that's occurring now, which is why when a pregnant woman starts to bleed from the vagina, that's like really scary and sad, because it almost immediately means that the person's getting an abortion. So now what would you have to do? Well, ultrasonography, right? That's it. You're just gonna have to look inside. It's a very easy question. There's nothing to think about. When anytime you have something like this where you need to look inside, you should just look inside. Use ultrasound. We saw this when we looked at it on our last video, on our last episode of CK, right? Everything was just do an ultrasound everywhere. All of these are do an ultrasound, right? Especially if POC are present, right? If you're seeing fetal components are present, then you definitely need to do an ultrasound. But the bleeding is good enough where you don't have to think of doing an ultrasound. If so, it is a complete abortion, and the POC should be sent to pathology to confirm fetal tissue with no other treatment. If POC are retained, it is an incomplete abortion, and manual uterine aspiration or DNC is indicated to get the rest of it out. Medical management with misoprostol may also be appropriate here to make sure everything comes out. All right. So it's a scary thing when a pregnant woman bleeds. It's not supposed to happen. All right. So now we're moving into normal labor and delivery, the obstetric exam. Leopold maneuvers. So what are Leopold maneuvers? These are used to determine fetal lie, longitudinal or transverse, and if possible, fetal presentation, breech or cephalic. We're going to see these things. Basically, Leopold maneuvers are a way to kind of touch on the mother's uterus and figure out if the baby is laying the way you would want it to be laying, with the head down and everything and perfectly vertical so it can just come out, right? If the baby is laying in any weird way, transverse or has breech presentation, cephalic presentation, whatever it might be, then you might have to do some maneuvers of like different kinds of massages that women can get to just shift the baby, shift the baby, turn the baby around so that the baby is at the correct position to just come out. Cervical exam. Evaluate the dilation, effacement, station, cervical position, and cervical consistency. Confirm or determine fetal presentation. Determine fetal position through palpation of the fetal sutures and fontanelles. Conduct a sterile speculum exam if rupture of membranes is suspected. And determine the station or engagement of the fetal head relative to a line through the ischiospines of the maternal pelvis. A negative station means that the fetal head is superior to this line. A positive station means that the fetal head is inferior to this line, which means that the head is about to come out, right? So the line, remember the line is through the ischiospines of the maternal pelvis. So the ischiospines are basically where the genes would sit at, right? And those ischiospines, you can make a line from there and see where the head is above that with the uterus. So this is something that is done with pregnant women when they're in for their obstetric exam. Now, if you've never seen this being done, then you should look up a YouTube video where you're seeing this entire obstetric exam being done. It'll really help you get a good understanding of what you would learn if you were in there for a rotation, for example. Definitely worth understanding. Definitely worth understanding. You would see if someone posted a video about it, it's probably a really good video where they do everything. So you want to find one where they're like, they're using measuring tape to measure from the xiphoid process over the uterus down all the way to right above the vagina to see the height of that belly hump, right? You want to see the ultrasound they're doing, everything. You want to find good videos of this entire obstetric exam, because it's not enough to just read about it. I've seen it in my OBGYN rotation, and it was like once I saw it, it was enough. I knew exactly what's being done. I understood the procedures that are followed with a pregnant woman during their obstetric exam. For labor, uterine contractions plus cervical change, that's when you know that labor is starting. Braxton Hicks contractions. Now, Braxton Hicks contractions are extremely common. These are just false labor. They're mild, irregular contractions without cervical change. So this is when the mother suddenly starts thinking, "Oh my God, I think I'm in labor," but she's not. But it's a nice normal, not nice, but it's a normal panic to have. It's a very common normal panic to have. But again, they probably haven't had a rupture of membranes yet. They probably don't have any cervical changes occurring. They just think it's labor, but it's really just the baby moving or some muscles contracting in their body somewhere. Management just involves nothing to do, just reassurance, right? Which, remember, is a very difficult answer choice to pick sometimes. So you gotta be very careful. With Braxton Hicks contractions, the concept is going to be a woman who thinks she's having contractions, but then you check for cervical change and there's no cervical change. Do not then think that it's that other question we just did, where there was no cervical change and then you do a cesarean delivery. That's not what's happening, right? So if you have a woman who's maybe at the 38 weeks gestational age, right? That's almost time for delivery, but not really. And then she comes in because she thinks she's having contractions, and you check and there's no cervical change. That's a Braxton Hicks contraction. You just tell her, "Oh no, that wasn't really your actual, it's not time yet. That wasn't the legit contraction. That was just you thinking it's a contraction. You're fine. Go back. We'll keep watching. You come back again, like maybe a day or two. and just keep checking, right? Oxytocin side effects, that's a whole different topic. Another key thing to keep in mind. So, oxytocin is basically used to strengthen labor contractions during childbirth, right? It can also control bleeding after childbirth. So, it's a very heavily used medication, very important medication, very critical in saving both the mom and the baby's life. Um, that being said, it can also be used to induce abortion, which is another case scenario that you might see oxytocin in, by causing contractions before it was supposed to occur. Now, you might get questions where someone was given oxytocin, and if the question is going to be about side effects, they're probably going to mention other medications that were given too. However, if you look at it, the side effects of oxytocin are nothing unique, right? Hyponatremia, tachycystole, and hypotension kind of occur from many things. So, thankfully, because of that, you probably won't really get a question just on the side effects of oxytocin. But definitely worth remembering the tachycystole part, right? So you're gonna have basically an increased heart rate, and it makes sense because if you think of oxytocin as something that's increasing contractions, then that's kind of like working out. So if you're working out, you're of course gonna have elevated heart rate. Right? So that's not so bad. Now comes the big topic: fetal heart rate monitoring. Another thing definitely worth watching actual videos of where they're like doing the fetal heart rate monitoring and talking about it, right? Like if I was in a rotation right now, I would love to ask a patient, if they're okay with this, and then I would take permission from the attending as well and show you guys what this looks like, when you do this. But this is the best I can do for you guys. So this is what we're gonna have to work with for now. I've gotten graphs of everything. All the different graphs and what they're all supposed to look like are here, right? It's a lot to take in, but you should just look at each thing one by one and grab it, right? Just make sure you understand what you're seeing. Look at it all one by one. So let's start from the top. So we have monitoring can be performed with an electrode attached to the fetal scalp, a method that yields more precise results. Or external monitoring can be conducted using Doppler ultrasound, which is a less invasive option. It'll be slightly less precise, but you don't need that level of precision anyway, right? So usually we do it with Doppler ultrasound, never really by attaching an electrode to the fetal scalp. That's scary. No mom is gonna want that. Stages of labor. This stages of labor thing was related to what we were looking at up here, so we already kind of talked about that. Yeah, you can just go over that if you need to. Continuous electronic fetal heart rate monitoring has not been shown to be more effective than appropriate intermittent monitoring in low risk patients. Right, so basically, don't keep monitoring fetal heart rate. You don't need to, right? Don't check it every day all the time. Just on regular intervals. Recommendations for fetal heart rate monitoring. In low risk pregnancies, review fetal heart rate tracings in the first stage of labor every 30 minutes and the second stage of labor every 15 minutes. Right? So this is in stages of labor, not like throughout the pregnancy. You really only check fetal heart rate monitoring during labor. But in high risk pregnancies, now there's a lot of high risk pregnancies. Anyone who has a bunch of comorbidities like obesity, hypertension, diabetes, long history of smoking, maybe they had drug abuse like alcohol abuse, cocaine, stuff like that. Any of these bad things, right? Maybe they had infections. High risk pregnancies, you review fetal heart rate monitoring pretty much every 15 minutes in the first stage and every 5 minutes in the second stage of labor. So you basically increase how often you lift, right? You double it in the first stage and triple it in the second stage. How often you're going to be checking, right? Components of fetal heart rate evaluation. So you're going to be looking at the rate. Normal rate is between 110 to 160. Usually questions will tell you the fetal heart rate is like 130, 140, and that's when you're okay. Right? So between 110 to 160 is how quickly the baby's heart should be beating. Now, if the fetal heart rate is less than 110, then of course that's bradycardia, and if it's more than 160, that's tachycardia. And there can be many reasons it's occurring. Just because you looked at the fetal heart rate alone does not give you the answer for why it's occurring. Bradycardia can be caused by congenital heart malformations or by severe hypoxia, secondary to uterine hyperstimulation, cord prolapse, or even rapid fetal descent. Tachycardia can be due to hypoxia as well, maternal fever, and fetal anemia. We're going to see a question soon, but generally speaking, we're going to see a bunch of questions soon, but generally speaking, Tachycardia is the one, both of these things occur the same way it would occur in us. Right? When we're hypoxic, when we're running out of air, our heart rate goes up. When we have fever, our heart rate goes up. And when we have anemia, our heart rate goes up. Right? Because our heart tries to get more blood out to different organs. So none of this is brand new. Okay, the only new thing here is the 110 to 160, which is the heart rate of a baby, right? The fetal heart rate. Fetal vitals are not the same as adult vitals. For the bradycardia, why would your heart rate be slow? Well, this is just because your heart isn't normal. Right? Congenital heart malformations. The most common congenital heart malformation, VSD. Okay. So other than that, if you have to pick any other heart malformation, it wouldn't be a fetus. You can't tell what kind of a heart malformation a fetus has unless you look at it, like do an ultrasound. In which case they would have to describe it to you, and if they describe the heart malformation to you, then you should know what it is. Variability. So that's the other thing. So you look for rate and you look for variability, right? And variability. So if we come down to this, you can see there's each of these graphs, all of them have two components to it, right? There's a top part and the bottom part. The top part is the fetal heart rate. The heart rate numbers are written in the middle here: 30, 60, 90, 120, 150, 180, 210, and 240. So we said that the normal range was 110 to 160, so that's like right here to right here. And so any heart rate in here is going to be considered normal, right? In between that range. And of course, you should look at the wave of the heart. It should be a nice wave with no changes, right? There shouldn't be any weirdness to the heart. You can see here, right, in the fetal heart rate, of course, it's significantly uglier, this line, than how nice and smooth this one is, right? So that's what we're looking at now, variability. Absent variability indicates severe fetal acidemia. So you can see how some of these are going to lead to exactly one answer choice. It's a one-to-one topic. So that means that if in a question they give you this, you have to pick fetal acidemia as an answer choice. So this means that this is just memorization of input-output, right? So you have to get this down, otherwise you won't know what output to pick. So very critical thing right there. Minimal variability, less than 6 beats per minute. This indicates fetal hypoxia or the effects of opioids, magnesium, or sleep cycle. What are we talking about variability? Well, let's take a look at, actually, let's finish reading this and we'll take a look at it. So minimal variability, very minimum difference in the bottom and the top of these heart rate monitors. So less than 6, that means there's hypoxia or opioids or magnesium or sleep cycle differences. Something is wrong somewhere, which means that the heart isn't beating as hard it would. Normal variability is the critical thing. Normal variability is 6 to 25 beats per minute. That means that, like this one right here has really, really unfortunate bad variability, because variability means that from how low to how high did you go. That's the variability we're looking at, right? And this is barely going high or low. It's actually almost a straight line, isn't it? So if it's almost a straight line, that's like it's staying at 120, right? With the variability maybe sticking between 110 and 120, but that's pretty much it. Not really. It's barely. It doesn't even really hit 120. That's kind of hard to see, but it doesn't really hit 120 or hit 110. It's just in between. So this is very low variability, as you can tell. It's a very, very simple, tiny curve, pretty much a straight line. So that's going to be your minimal variability aspect, which could be somebody who has some kind of issue. Normal variability is 6 to 25. Too much variability is more than 25. Right? So that's going to be fetal hypoxia may occur before or a decrease in variability. So of course, fetal hypoxia, you can see, doesn't really indicate a one-to-one ratio here, right? It can occur in minimal variability or it can occur with marked variability. It really depends on what is happening. For example, when you just run out of air right now, you would breathe really, really fast and your heart would beat really, really fast. But if you've been out of air for a long time, then you start dying. So then your heart doesn't beat fast. Right? So that's the difference we're seeing here. So in the beginning, you might have really high variability because you just became hypoxic. But then if you stay hypoxic for like a good 4 hours, then your heart stops beating. Okay, so that's kind of what we're seeing here. So fetal hypoxia, you don't get a one-to-one answer from that. You would have to really think more about it. The one-to-one was so far just the fetal acidemia. If you see fetal acidemia, you should think of absent variability. If you see absent variability, you should think fetal acidemia. Right? So acid gets rid of variability. I always thought of this as like if you throw acid on anything, right? If you put acid on anything, there's no variability anymore. It all just melts, right? So it all comes down to a flat line basically. So that's how I always remembered it. Absent variability, acid. A sinusoidal variability, that's actually what this graph is. Sinusoidal variability is, this is a serious fetal anemia person. Serious fetal anemia. A pseudosinusoidal pattern may also occur during maternal meperidine use, which I've never seen a question on, but that's like a one-on-one thing. So basically you can see the same graph with meperidine. Right, so a serious fetal anemia will lead to a sinusoidal pattern. So that's this question. This graph right here was showing you a sinusoidal fetal heart rate, the smooth wave-like oscillation with fixed amplitude of 5 to 15 per minute and a frequency of 3 to 5 cycles per minute. Below, it's considered ominous. This is extremely bad. The baby might die. It's associated with severe fetal anemia, possibly due to bleeding complications, and requires urgent cesarean delivery, after which you would have to fix the baby's anemia ASAP. Okay. So another thing to keep in mind is you see here it says 60 seconds. So from here to here is 1 minute. Each of these solid lines is 1 minute. So you're seeing that in 1 minute you have 1, 2, 3, right? That's 3 humps right there. So that's what they're saying, 3 to 5 cycles a minute. 3 to 5 cycles a minute. Sometimes there might be more than 3 maybe. That's why they're saying 5. But yeah, each of these lines is a minute. The solid vertical lines, as I've drawn right here, the red horizontal lines are showing you 1 minute of time has passed. Okay, and the dashes I drew were to encompass that this is the range of normal heart rate. Normal heart rate, but not normal variability. This baby doesn't have normal variability in the heart rate. The heart rate is pretty much flatlining, and then that flatlining is obviously flatlining. So anytime we think of flatlining, like with an ECG, for example, that's pretty much a dead person, right? So that's something that should be pretty easy to work on. In sinusoidal fetal heart rate stuff, you don't really need to worry about the contractions too much, and we haven't looked at this yet. We haven't looked at the bottom half. Right now, we're really just focusing on understanding the top half of this graph, fetal heart rate. Okay. Accelerations, decelerations. So accelerations, onset of an increase in fetal heart rate of more than 15 beats above baseline to a peak in less than 30 seconds. Reassuring because they indicate proper function fetal autonomic nervous system. So never get freaked out because of accelerations. Accelerations are basically saying that the heart rate suddenly kind of went up for a little bit and then came back down, right? And it's just showing you that the baby's, responding to the environment. Decelerations, however, are not normal, right? So in a given day, our heart rate could go up just because we responded to something, either emotionally or physically. But our heart rate should only really go down when we're sleeping, right? Or in like completely resting phase. We're gonna see decelerations now here, where the deceleration is not normal. So you can see I've got a bunch of questions here with the graphs. I left space for more, but here is where they're kind of teaching you now how to work with understanding what it means to look at contractions. So there's early deceleration, late deceleration, and variable decelerations, right? And here's a question to kind of show you how that works. So honestly, in my opinion, looking at these things has been a little difficult in the beginning for pretty much every student I worked with. But unfortunately, there's no other way to do it. It would not make sense to do the question first and then come to the example. Come to the book. So let's look at the book first. Whether or not you understand it, just wait. And then we're going to look at the questions and it should make sense. So what is early deceleration? A visually apparent gradual decrease in fetal heart rate with a return to baseline that mirrors the uterine contraction. All right. So what we're looking at is the top half and the bottom half of the same things we were looking at before. They just drawn it differently here. Okay. So this up here is the fetal heart rate stuff. Down here is the contraction. They have these terms now. There's the onset, the recovery, and the nadir. Okay. So you can see there's 3 different places. So visually apparent gradual onset to nadir in more than 30 seconds, right? Decrease in fetal heart rate with a return to baseline that mirrors the uterine contraction. So you can see that here, right? That this point and this point are pretty much occurring at the same time, right? That's the only critical difference in all of these. As you can see here, this is not occurring at the same time. Here is definitely not occurring at the same time, right? That's the main point we're looking at, the nadir. The nadir point, which is the lowest point, I believe that's what that word means too. Let me just check real quick. The nadir is a direction pointing directly below a particular location. It is one of two vertical directions at a specified location. It's a very big mathematical term, also used for maps and stuff. But here we're just looking at this lowest point, this lowest point in the heart rate stuff, right? The baby's heart rate. So you can see that what they're telling you is this: the time it takes from onset to recovery should be a little more than 30 seconds, but it should occur with the maternal contraction, right? They should occur together. That is an early deceleration. Why did it occur? The etiology: head compression from uterine contractions, and this is normal, completely normal, right? So whenever the mom's contracting, she's compressing the baby, so the baby's heart rate kind of falls a little bit and then comes back up. And it should occur together because this caused that, right? The contraction caused that, so they occur together, right? If they're not occurring together, that's a little weird, right? So the contraction is what caused the deceleration. That's it. Super simple, right? So early is the easiest one. It's pretty much never a question because it's the easiest one. This is just normal. There's nothing pathological here, so there's nothing to question you on. If they do give it to you, then you understand nothing needs to be done. You pick the answer of nothing needs to be done. Reassurance or continue normally or whatever terminology they use, nothing needs to be done. Then you have this one. This is, in my opinion, one of the most commonly tested because the other one looks really freaky, so it's also very easy to catch. Late decelerations. So it's late because you could see that the two things didn't match, right? They didn't occur together like they did up here. The nadir is occurring after the contraction. So in a sense, the nadir is late, right? Occurring together was on time. Now the deceleration is late. It should have occurred with the contraction, but it occurred after the contraction. That's pretty weird. So late deceleration, a visually apparent gradual onset to nadir in more than 30 seconds, decrease in fetal heart rate with return to baseline whose onset, nadir, and recovery occur late. Right? They occur after the beginning, peak, and end of uterine contraction, respectively. Right? So basically, the beginning of contraction occurred here, the onset of deceleration occurred there, the contraction occurred here, the deceleration occurred here, and then the ending of the contraction occurred here, and recovery occurred there. So all three of those phases, as you can see if I connected lines from them, all three of those phases are slanted, right? They're late. That's why they're all looking slanted like that. Generally speaking, the line should have been nice and straight like that. So the red lines I drew are mimicking these gray lines that they have here, which are nice and straight, right? So these lines will not be on your fetal heart rate monitor, right? So this your fetal heart rate monitoring traces are gonna look like this, just blank. There's no extra lines. This is how they're gonna look like. So when we look at questions, we'll understand it better. But that's occurring. So why does this occur? Why do you get late decelerations? Well, late decelerations occur due to uteroplacental insufficiency and fetal hypoxemia. Give me 1 second. So uteroplacental insufficiency and fetal hypoxemia, both of these case scenarios. So what's happening here? Well, we're going to learn about those case scenarios more as we go on. The point right now is to memorize the association of late decelerations with these two things. So I did this color coding thing here that somehow my math major mind and my imaginary mind was able to see all of this. So I color coded this like that. It's kind of how I always look at the word now, right? So uteroplacental at the end has this late right there, if you don't really look at the end too much. And that's how I always remember it's late deceleration. This is actually still pretty new stuff for me. I even though I finished CK, like it was when I was taking my CK, it was still very new stuff for me, and it wasn't exactly stuff I had perfectly memorized. So I needed this. Eventually, of course, you won't need it, but it really depends on how much you got studied, right? Imagine the contraction choked the baby. leading to insufficiency or hypoxemia. And that's all that's happening here. That's another way to remember that, right? So if the mother's contraction isn't, normally it's supposed to compress the head, but maybe the baby isn't placed ideally inside the mom, right, inside the uterus. So then the mother's contraction may have actually choked the baby in a sense, and not literally choke the baby's throat, but maybe choke the umbilical cord, right? Choke one of the blood vessels, any of these things. If those things are getting choked from maternal contractions, then of course the baby's heart rate will fall down after the contraction, and that's what we're seeing here. So it should be pretty commonsensical in that aspect now that you've learned it, right? This is stuff that becomes common sense after you learn it. It wasn't common sense because it was not natural. This isn't a natural graph. This is something people made up. But it's common sense after you understand it. It makes sense now. Last thing we have here are variable decelerations, which look completely different. So they're showing you here basically that any one of these first three things can occur, right? The onset can be either before the contraction, with the contraction, or after the contraction. The onset can be anywhere, but the nadir occurs way after the end of contraction. Okay, so this lowest point occurs much later on, and it's going to be also very short. As you can see, a less than 30-second curve. You see how the curve here was nice and wide? That time span from beginning to end was more than 30 seconds. Here, it's really tiny. It's a very small curve. So if I fit it in here, it's kind of going to be like that. That's just a very small curve. So the variable deceleration occurs quick, and it can occur at any weird pattern. So your graph can look like that, right? Or you can have it from there or from here. But the nadir point, that point is from wherever the onset occurred, is always going to be less than 30 seconds. Right? So coming back up is going to be less than 30 seconds. So in all reality, it's supposed to be like something like weird like this can occur, basically. That's going to be the first one, right? The second one, again, less than 30 seconds. And then this is the last one, which they completely drew for you, right? Like that. Those are tiny ones. You see how the distance, the width of each of these is less than 30 seconds? That's what we're talking about. Right? Never was it like that. You see how nice and fat this is? It's more than 30 seconds. Remember that the y-axis, the x-axis, the axis on the bottom right here, the horizontal axis is time, right? So x-axis is time, so that's kind of what we're looking at. Abrupt, visually apparent decrease in fetal heart rate, 15 beats per minute below baseline, lasting for more than 15 seconds, but less than 2 minutes. This is also really important to watch out for, and thankfully it's a one-to-one association. One-to-one association. If you see variable heart rates, variable decelerations, it's an umbilical cord compression. Done. Right? So this is why the most commonly tested is late deceleration, because there could be two different reasons, and there could be other reasons that maybe aren't listed here. And it's not so obvious, but to catch it is pretty easy. And all of these now that we've talked about it, all of these don't look so confusing anymore. Now we get what's happening, right? Either the baby's deceleration occurred with the contraction, occurred a little after the contraction, or occurred in a freaky way where it was less than 30 seconds. Right? A very small contraction. A very small deceleration. Right? The contraction force is indifferent. The contraction is contraction. The mom will contract however she wants to. Maternal contractions are never really weird in any question. The thing that's changing is the fetus, because the mom is a fully grown adult. We're assuming that the mom is stable and good pregnancy, no preeclampsia, any of that stuff, right? So the contractions for the mom is always going to be the same. The baby is a developing, fragile fetus that can change, right? So now let's take a look at this question here. This question was for umbilical cord compression, this answer choice, right? 30-year-old woman, so that's a good age for pregnancy as far as step 1 is concerned. Remember, that's step 1. Anyone pregnant after age 35 on step 1 is considered a late pregnancy. So 30-year-old woman, G1P0, so it's her first pregnancy, is at 42 weeks gestation. So this is a prolonged pregnancy, right? We usually want the delivery to occur by 40, 41 tops. This is 42. This is too long now. She's been pregnant for too long. 42 weeks gestation, comes to the hospital with regular and painful uterine contractions. Well, about time. On admission, she's stable. Vitals are stable. Estimated fetal weight is 3.8 kilograms. So that's about an 8-pound baby. Digital cervical exam shows the cervix to be 4 centimeters dilated and 100% effaced, with the fetal vertex at the 0 station. Fetal heart rate monitoring shows a baseline of 140, moderate variability, spontaneous accelerations, and no decelerations. So the fetal heart rate monitoring is great. That's normal. That's wonderful, right? Because the 140 is between the 110 and 160. The moderate variability is acceptable. Moderate variability must mean that it's normal variability, like this one right here. Coming back to what they said, normal variability 6 to 25. That's a moderate change. Okay, 6 to 25 changes, so that's normal. And then spontaneous accelerations, that's normal. That's showing that the autonomic nervous system of the baby is working. No decelerations, which is also okay. An hour later, the patient is noted to have grossly ruptured membranes. Temperature, blood pressure, and pulse are still pretty much stable. On repeat digital cervical exam, the cervix is now 7 centimeters dilated and 100% effaced, with the fetal vertex at the +1 station. So that's kind of weird, right? Because now that's where the problem is. The fetal heart rate monitor was perfectly fine so far, but in the beginning they said that the mom was 4 centimeters dilated, right? 4 centimeters dilated, and the vertex was at 0 station, right? And then now she's 7 centimeters dilated, but the vertex is at the +1 station. So that's kind of interesting, because if we go back to the first graph we looked at, right, if we go back, let me just take this with us to where we are right now so we can compare what we're doing. Because they're not giving you a graph in this one, but they're kind of giving you the numbers for the graph, right? So basically what we're seeing in our woman here right now is that at some point, we don't know what timing they're using, but let's say it was time 0, then she was at 4 centimeters, she was here, and the fetal the fetal head was at the 0 station. So it was starting the gray. I'm going to use an open circle for the gray line and a solid circle for a solid dot for the black line. So already the starting points don't look too good. And the starting points don't look too good, because normal, you can see what the normal is supposed to look like. Right? This fetal head station should have been much higher up. -2. The fetal head should have been deeper inside the mom, right? Instead, it's not. The fetal head is pretty much ready to come out, which makes sense because she's 42 weeks gestation. And so the reason I'm doing this is because this graph will not always be given to you. Right? They can verbally give it to you, like they're doing in this question right now. Right? In this question, they gave me the beginning part. They gave me the 4 centimeter dilation of cervix, and that the fetal head is at 0 station, which is this 0. That's not good. Right? The baby's ready to come out, but the dilation hasn't occurred enough. And then I don't see, they didn't give how much time has passed. Actually, yeah, an hour later. So 1 hour has passed. Right? 1 hour has passed. So we went from 0 to 1 hour, and boom, her cervix is dilated from 4 to 7. So her cervix is dilated from 4 to 7. Right? So I'm going to draw a solid line like that. So that's pretty quick dilation. That's a very quick dilation. Right? And on top of that, you have to remember that 6 is the cutoff point from latent to active. So she just went into 7. So that means she's in the pink area. So she's in active labor. Right? She's in active labor with the cervix that's dilated 7 centimeters. She's in active labor. So if she's in active labor, where's the head now? Well, the fetal vertex is at the +1 station. So that also is now ready to come out. It's at the +1 station. So that's over here. So I'm going to draw my dash line. And you see how this is really bad, right? You can see that the crossing over was supposed to occur here. Much later on, it's already occurring here, right? Also, it's not in a good area. It's in the blue area. The actual labor should be occurring in the pink area. And the crossing over is happening here in the blue area. So you see how I was able to reproduce this graph without actually being given a graph? That's because that shows that you're understanding what's happening. So your understanding of what's happening in this question should be based off of being able to visually do this graph for yourself. You know, you're not going to have the graph every question, and drawing out the graph would take some time. You know, time management is the name of the game for STEP. But generally speaking, you don't need to do all of that. I did all of this just to show it to you guys. On your actual test, you could at least do this, right? You could write this down. You could write this down. You can make an arrow and say this was 1 hour, right? 1 hour, it went from 4 centimeters to 7 centimeters. 7 centimeters is active labor. Fetal head went from 0 to +1. So that's still in the blue area. That's not good, right? That's not good. The head is about to come out, but the mom hasn't dilated entirely yet. Something is weird. So then they go on. Fetal heart rate monitoring is shown in the exhibit. I put the explanation exhibit, so there were no markings. Nothing was drawn on it, okay? There's nothing drawn on it. They just gave you the lines. What is the most likely cause of the patient's fetal heart rate pattern? Okay, so if we look at this, right, we can see that the baby is having some weird drops, right? These drops are your decelerations, right? Because the heart rate went from 160 to down to 90, right? 160 down to 90. And then remember that each of these was 1 minute, right? So you could see that this drop has occurred for more than 30 seconds because it's almost filling the entire thing. From here to here is 1 minute. This is a little more than halfway. So it's more than 30 seconds. So, wait, 1 minute. Let me just move this. Where are we? Sorry, from here to here is 1 minute, right? And they drew this line for you, but it wouldn't be drawn for you in the real question. This is supposed to be halfway right here, right? And this would be 30 seconds. You can see that from onset to nadir is less than 30 seconds, right? This is often very hard to catch in questions, right? The way you're going to catch this in questions is because when it's more than 30 seconds, it'll be very obvious. So when it's less than 30 seconds, it's not that obvious. What are we looking for? We're looking for this downward fall. This should take more than 30 seconds to occur, right? So when it does occur, let me draw it over here. It would usually go down in a very wide way where you see how it's kind of past the midpoint now, right? So this went from here to here. It would take more than 30 seconds and then it would come back up nice and fat, and you see how this whole thing is going to be more than 1 minute now. That's what we're really looking for. If it went down and came back up within a minute, that means that each half was less than 30 seconds, right? It clearly went down and came back up within 1 minute. It didn't even take 1 minute. It actually came back up much quicker than 1 minute. So that means each path was less than 30 seconds. So the approaching to nadir took less than 30 seconds. You don't need anything else now. Once you saw that it took less than 30 seconds, you know that is variable deceleration. That's the only time it takes less than 30 seconds, right? The reason it's called variable is because it could occur here with the contraction, occur before the contraction or after the contraction. In fact, you could see the variability because if you look at the next one, look at the difference. It's much further off from the contraction, right? You can see what they're showing you. This graph is perfect. This graph does a great job teaching you exactly what you're looking for, right? So the whole thing is pretty obvious. The whole thing is pretty obvious that this must be variable contractions. Sorry, variable decelerations, right? Variable deceleration. Where here, this one occurred somewhat a little before the contraction. Here, it doesn't even occur during a contraction. There's no contraction there. It occurred much later after a contraction. So that's the variability. Plus, on top of that, each of these approaches down is less than 30 seconds. It should take more than 30 seconds to come down and more than 30 seconds to come back up. It didn't take that much time. The whole thing occurred in what looks like about 40 seconds, with leaving 20 more seconds after that. Right? Because here to here is 1 minute. So that's what we're looking at. Once you see variable deceleration, it's a super easy question. Umbilical cord compression has to be the answer. This patient's heart rate has a normal baseline of 110 to, why did I write 10? I think it was supposed to be 110 to 140. Yeah, because it goes up either way. She has a normal baseline. Oh, it is. Yeah, normal baseline 140, right? So this will be 110 to 140. Moderate variability, which is usually 6 to 25. So we talked about this. Fetal heart rate monitoring link. That line we talked about, we broke it down. Everything was normal there. And variable deceleration, which is not normal. That's what we're seeing here. Abrupt decrease in fetal heart rate. That takes less than 30 seconds to reach nadir. And then nadirs at a heart rate of more than 15 per minute, below the baseline, which is too low. It got much lower than baseline. That's the other problem here. It shouldn't go that low. You see how it doesn't go that low? You see the difference between these two, right? That went a little too low. It went from 110. Sorry, no, this is 140. It went from 140 all the way down to 90. Right? So from 140 to 90 is too big of a jump. That's not normal. Right? And then the fact that it took less than 30 seconds, that's not normal. And then the fact that sometimes it occurs without a contraction, that's not normal. There's too much variability. It's so easy to see it that you always get this question right. It's just learning it is the first thing you have to do to get the question right. But it's very easy to see it, right? So the decrease was more than 15, right? More than 15. It went from 140 to 90. That is a decrease of 50. The duration of the entire deceleration is more than 15 seconds and less than 2 minutes. The duration and depth of each deceleration vary and are not always associated with contractions, as you can see here. Right? Variable decelerations are common after rupture of membranes and a decrease in amniotic fluid volume, as they can result in umbilical cord compression and occlusion of the umbilical vessels, particularly during contractions. Variable decelerations occur as a response to changes in pressure, as compression and occlusion of the umbilical vessels cause an increase in fetal systemic vascular resistance and blood pressure, and a reflexive rapid decrease in fetal heart rate. The fetal heart rate returns to baseline as the umbilical cord decompresses. First-line management of recurrent variable decelerations is to do intrauterine resuscitation. So you can tell from the table that they gave in first aid, they didn't tell you how to deal with it. Right? So this is why the book is so incomplete. What would you do? They told you how to read it. They told you this is a variable deceleration. Why did it occur? It occurred because of umbilical cord compression. They should have had another line here telling you what are you supposed to do to manage this. So to management, intrauterine resuscitation with maternal repositioning, left lateral or all fours. These are going to be actual answer choices. Right? You're going to have to tell the patient to lay on their left lateral side, right, or to get down on the ground on all fours. To do these things, what happens is if you're down on the ground on all fours, you let the baby hang, and now you stop compressing the umbilical cord, right? You need to stop compressing the umbilical cord. That's the issue with this pregnancy right now, this woman, which may reduce cord compression and improve fetal placental blood flow. Of course, this isn't a permanent solution though, because as soon as she goes home and lays on her back, boom, she's going to be compressing the cord again. So either way, this is going to be still an answer choice you're going to have to pick, and you have to understand why that's the answer. An amnio infusion can be administered. So now that's the other more more long-lasting solution, because you can't have the mom on all fours forever, right, until she delivers. So what do? You do amnio infusion. You basically put back more amniotic fluid because she lost some of it after the rupture of membranes. It was due to the lack of amniotic fluid that the cord was being compressed. There was no amniotic fluid to keep things nice and floating. So you just give her saline into the intrauterine cavity and it should stop cord compression. An amnio infusion artificially creates more amniotic fluid, which can reduce umbilical cord compression and decrease variable decelerations. And save the baby, save the pregnancy, and everything's going to be okay. So not the most fatal thing, but if you don't deal with it, the baby can die. All right? So that's what's happening in this. Now, again, this is all brand new stuff compared to step one, but it's not ridiculous. In fact, this is so easy. I would have rather had some of this on step one than some of the things we do have in step one, which are really dumb topics that you're never really going to use in your everyday medical practice. Like, I'd rather have this than have biochem. That's for sure. So this isn't so bad at all. It's very easy to understand what's happening once you learn it, especially once you learn it correctly. So hopefully I'm doing a good job teaching it. And then it's really easy to catch it once you've trained your eye to see what you're supposed to see, which is what these graphs are helping you do, right? So this graph was a perfect graph to show you variable deceleration. Now let's take a look at some other things. So right here we have another question. 28-year-old woman, G2P1, so this is her second pregnancy. She's young. At 38 weeks gestation, so she's approaching delivery time. So the reason I stop and say these things, because these are things that I think of as I read the question. Is admitted to labor and delivery due to pre-labor rupture of membranes. Okay. Clear amniotic fluid has been leaking continuously for the last 2 hours. She has irregular non-painful contractions and no vaginal bleeding. Prenatal care during this pregnancy has been fine. So she's been coming regularly for all her prenatal care. And her previous pregnancy ended in a term vaginal delivery. Excellent. Temperature, blood pressure, and pulse are normal. Cervix is 3 centimeters dilated and 50% effaced with the fetal vertex at the -2 station. So that's appreciable, right? The -2 station. So the baby's head is still all the way inside, and the cervix is only 3 centimeters dilated, not too much. So she's still in the latent phase. Fetal heart tracing on admission is on the left. So this one, okay, with no labels this time. I put all the graphs this time. So I put the one with the labels and without the labels, and some other things that are going to be involved. Fetal heart tracing on admission is as on the left. After an oxytocin infusion is started for labor augmentation, she begins to have regular painful contractions that require epidural anesthesia. So they gave her oxytocin because it doesn't look like she's contracting enough to get the baby out. 2 hours later, her vitals are still good. So now 2 hours have passed, right? So in 2 hours, we know that it's supposed to be 1 centimeter, more than 1 centimeter every 2 hours, right? So there should be enough change. So on repeat exam, the cervix is now 7 centimeters. So it went from 3 to 7. That's a 4 centimeter change. Perfect. 100% effaced with the fetal head at +1 station. So it's still too far inside. It's still from +2 to +1. It still hasn't reached the point of coming out, passing 0. Current fetal heart tracing is as on the right. What is the best next step in her management? So you can imagine how intimidating this question must have been for students, because they were given this for pre, right? And then this one post. They were given 2 fetal heart rate tracings, right? And they're being asked what's happening. Well, again, the reason they can do this to you in a question is because looking at these things should be like secondhand nature for you, and it's just going to have to be something that you naturally read as if it's like reading a sentence in English. So if you look at the first one, right, let's read it together. If we look at the first one, first thing I'm seeing is that the mom is not having regular contractions. She's not having many contractions at all. In fact, in the beginning, she doesn't have any contractions until right here she gets 1, and then much later on she gets a second. This is the reason they gave her oxytocin. And they gave her oxytocin to make her get contractions. So far, so good. So now, of course, I can see, I'm comparing pre and post because that's what they're making us do, right? So now we can see in the post, there are regular contractions. It's not irregular, it's regular. 1, 2, 3. It's happening in a good pattern. Now let's look at the baby. So the baby's fetal heart rate looks pretty funky in the beginning, right? It looks pretty funky, but is it within the normal range? Well, the normal range was 110. Let me just put it here, 110 to 160. Right here. So it looks like sometimes the baby's heart rate is going a little higher. It's going a little higher than 160. We can see it keeps going above. Here it's definitely above 160. Right, above 160, and it's staying a little above 160. So we're seeing some level of fetal tachysystole, and the baby's heart rate is going up. Why is the baby's heart rate going up? Well, there could be many reasons right now, but oxytocin will cause the mom to have more contractions, and then you can see that the baby's heart rate is no longer doing that. But now, what am I seeing? Now we're seeing decelerations. Right? There's decelerations. This is a deceleration when the heart rate goes from baseline to down. And look at this. It's a very beautiful deceleration. It goes from here all the way to there. That is your nadir. I'm gonna label it N. Nadir. And you can see that from here to here is 1 minute, and this is the 30-second mark, that it took more than 30 seconds. Right? More than 30 seconds. So this is a good deceleration. A healthy deceleration. Now the next thing we need to look at is, did the nadir match with the contraction? Well, the nadir did not match with the contraction. In fact, the nadir is occurring after the contraction. So what does it mean? And then if we look at more of them, we can keep seeing it. Contraction occurred, then nadir occurred, right? Slanted line. Contraction occurred, nadir occurred. Contraction occurred. We can keep seeing that everywhere, right? So this, we already talked about. This was uteroplacental insufficiency. This is you choking the baby, right? This is basically every time you contract, you stop the baby from breathing, and then when you stop contracting, the baby's heart rate fell because you choked it. So what do? You discontinue uterotonic agents, you stop the oxytocin. That's it, right? If you continue current management, the baby's gonna die. That was the other answer choice 20% people put, right? Which is probably because they weren't done studying this. Now, it took me a long time to explain this to you, but it's not going to take you this long to actually answer this question. I'm making sure I break it down, right? I'm showing you exactly why the doctor did what they did, which is giving the oxytocin. I'm explaining why we cared. We cared because two reasons. The fetal head wasn't coming out enough. It was still, after all this time, only at +1 station. We need the fetal head to come out. If we look at our thing again, right? We went from what was it? 3 centimeters in -2 station. Right, so 3 centimeters and -2 is still in the active area. Wait, where was I? Where's the first one? The first one, yeah, 3 centimeters and -2 station, and then it went from there to 7 centimeters and +1 station. Right, so it went from -2 to +1, which is good. -2 to +1 is good, but then the 3 centimeters to 7 centimeters is not good because she's not getting enough open. It needs to open up. It needs to open up more. 8, approach 10, hopefully, so that the baby can come out. Right, so that's kind of what we're seeing. So, but it wasn't too bad. It's pretty decent. The baby is almost ready to come out. The opening is almost enough. We just need a little bit more. So you give oxytocin. Give the oxytocin, but then you need to stop the oxytocin because you can see that the oxytocin is causing choking of the baby. Right? Not bad at all. This is actually, these questions are so much easier than cardiovascular, heart related, heart sound questions or any of those things were way in the beginning. The cardiovascular stuff is second nature to me now after having looked at it so many times. But when I did take my step 1, it was still a little intimidating for me. You know, and it was still something that I wasn't very solid on. It was still something that wasn't extremely easy. This, however, is actually really easy. Right? There's nothing weird here. Her fetal heart rate tracing has recurrent late decelerations, a sign of uteroplacental insufficiency and impending fetal hypoxemia and acidemia. Her fetal decelerations are most likely due to uterine tachysystole, defined as more than 5 contractions every 10 minutes. Uterine contractions temporarily interrupt intravillous blood flow. Excessively frequent contractions, as in her, may cause fetal compromise as a result of decreased uteroplacental blood flow during contractions and inadequate recovery time between contractions. Although uterine tachysystole can occur in spontaneous labor, there is an increased risk with induced or augmented labor, where you're actually causing tachy contractions, right? More with the oxytocin. Uterine tachysystole is managed with supportive measures like lateral maternal positioning, tacholysis, which is a tocolytic, it'll end the contractions, and discontinuation of any uterotonic agents until the excessive uterine activity and resulting of fetal decelerations resolve. Right, so you discontinue the uterotonic agents, check again that the decelerations have gone away, the baby's doing okay, and you're good. Right, so this is showing you what's happening here. Right? And yeah, I think that's about it. So that takes care of that topic. One last one. Let's take a look at this one. This is showing you a late deceleration, and then we're done for today. 28-year-old woman, G2P1, at 37 weeks gestation, comes to the hospital due to severe abdominal and back pain. Her prenatal course has been uncomplicated, and her only med is a daily prenatal vitamin. She had a prior cesarean delivery and is scheduled for a repeat cesarean at 39 weeks gestation. Blood pressure is very low, pulse is fast. Fetal heart rate tracing is shown to the right without any marks. Physical exam shows a palpable irregular protuberance in the lower abdomen and moderate vaginal bleeding. What is the most likely cause of her presentation? Well, now this looks really weird, right? This graph looks a lot different from anything we've looked at so far. So what's happening here? Well, if we look at the mom is having really strong contractions, and it's happening in pretty big gaps. Okay, and then if we look at the baby's heart rate is going from, the lowest it is right here, maybe about, I would say like 80, and it goes all the way up here to 190. So the baby has a lot of variability in the heart rate, and this fall from up there to down here is called the nadir, right? That's the deceleration. So the deceleration is nice and long, takes forever, finally gets there, and then comes back up, takes a long time. Just coming down it took more than 2 minutes, almost took 3 minutes. So that's definitely more than 30 seconds. So if it's more than 30 seconds and it looks this funky, the only last thing to look at is, did the nadir match with the contraction? It did not. It occurred after the contraction, right? And then the recovery is taking so long that after this contraction, if there is another one, it's going to be much later off the screen, right? So in one monitor screen, all we fit was one deceleration. This is a late deceleration. So coming back to here, this is just like here, right? It's just another late deceleration. We can't call it a variable deceleration because it was more than 30 seconds, right? Less than 30 seconds. That's the difference between the two. This is just a late deceleration where you could tell it's late because of the slanted line I drew here, and it's more than 30 seconds. And that's the two things. So now, what could have caused her presentation? 20% of people pick abruptio placentae. Abruptio placentae would kill the baby, right? Abruptio placentae is a step 1 topic right here, right? Premature separation of the placenta from the uterine wall before delivery, right? Could be due to trauma, smoking, hypertension, preeclampsia, cocaine abuse. It's abrupt disconnection, right? Now, depending on how the placenta was placed in the mom, it could lead to blood leaking out, or it could lead to blood stacking up as a hematoma. Right? In our patient right now, blood is leaking out, so her placenta must have ruptured like that. Now you can only imagine if the placenta is rupturing, the baby's gonna die, right? So it's painful bleeding. In the 3rd trimester, you could get DIC from it. You could get maternal shock, which we do see. We do see maternal shock. Blood pressure is very low, pulse is fast. And so we see maternal shock. And then fetal distress, we definitely see fetal distress as well. Clearly, right? The heart rate goes up to 190 and then falls down to 90. That's a variability of 100 points right there in heart rate. So this is really bad. But what occurred here was not abruptio placentae, it was uterine ruptures. How do you tell? Well, you can tell because in abruptio placentae, right, you would not get this kind of late deceleration. In abruptio placentae, the baby's heart rate would start becoming flatline. Why would it become flatline? Because the baby's not going to be getting enough blood or heart rate or anything. The baby's going to die, right? It did not become a flat line here. This is actually showing crazy deceleration, right? Crazy deceleration. So that's not abruptio placentae. That was number 1 way to figure it out. Number 2 way of figuring it out was that with abruptio placentae, right, the contractions would not have an effect on the baby anymore, because contractions are supposed to compress this cord, right? This cord is supposed to get, every time the mom is contracting, this umbilical cord is getting compressed. That's what a late deceleration usually is. But in our patient, if it was abruptio placentae, the cord isn't even attached anymore, so the contractions would have no effect, right? In abruptio placentae, the maternal contractions would have no effect on the cord because the cord isn't even attached anymore. But in our patient, the contraction clearly has an effect on the cord, so the cord is still attached. So it's not abruptio placentae. She most likely has a uterine rupture caused by complete uterine wall disruption. The most common risk factor is prior uterine surgery, which leaves a weakened, inelastic myometrial scar that is prone to tear with uterine distension or labor contractions. Uterine rupture causes a sudden onset abdominal pain, and since the pregnant uterus is highly vascular, bleeding can quickly lead to intra-abdominal hemorrhage, vaginal bleeding, and shock. Uterine rupture may also cause fetal parts to partially expose into the maternal abdomen, which was palpable as an irregular protuberance in this patient's lower abdomen. They were actually feeling a fetal part in the mom, right? An abnormal fetal heart rate tracing is often the first sign of uterine rupture and can present as late decelerations or variable decelerations. Management is with laparotomy and cesarean delivery. Get the baby out, obviously, right? Don't hesitate in picking that as an S choice if it looks like the baby's about to die and there's no hope of the baby coming out vaginally. Right? Just do cesarean delivery. The baby is alive. Clearly, heart rate is working. Right? Get the baby out. That's it. Right? Abruptio placentae presents similarly with the shock and all of that, but it doesn't have the irregular protuberance of the baby, and it also doesn't have the better point that I made, where contractions will not impact the uterine. The contraction will not impact the fetal heart rate, because the contraction only impacts the fetal heart rate if the umbilical cord is being compressed. But in abruptio placentae, the umbilical cord is detached, so you can't even really compress it anymore. It's not there anymore. All right. So that's the concept there. I really hope that this was helpful. Feel free to reach out. Anyone that's here right now or watching the video later on, feel free to shoot me an email if there's anything that doesn't make sense, anything that seems confusing, or if you run into any questions you're doing on your own practice time which involve these things and maybe you didn't understand it. Here, there's more graphs from UWorld showing you each one of them that we looked at today. There's these two graphs that the book has with variable fetal heart rate decelerations. Right, you could tell this one is variable right here because it's too skinny. It's going to be less than 30 seconds, right? Really easy to cast that. Really, really easy to cast that. It's also variable because these both occur in the same baby, but look at how different they are, right? And another way it could be variable is that one can mask the nadir, the other one may not mask the contraction at all. So all kinds of things can occur. Here in the bottom one, they're showing you a late fetal heart rate deceleration. The late ones are always very obvious. First of all, this should be a very slow, so it's more than 30 seconds, right? It's taking a long time. It's not a V, it's a big U, okay? And that each one should occur after a contraction. After a contraction. So contraction occurred, you choke the baby. Contraction occurred, you choke the baby. Late fetal decelerations. Super easy, right? Nothing confusing here, nothing crazy. Of course, it can be confusing in the beginning, so don't hesitate in asking a question. And, just keep working on it. When you do these practice questions, you'll see a lot of it is going to start making a lot more sense. And then in the next video, we'll go into complications of pregnancy.